Hello, and welcome to the University of Washington Cardiometabolic Echo Session 1. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington Diabetes Institute. I'm really excited today to kick off the Cardiometabolic Echo program. And one thing we want to highlight is that for every session, we do ask that you help us empower our patients living with the cardiometabolic and diabetes disease, and note that this is a safe space and that there's zero tolerance for making people uncomfortable. Because really the heart of ECHO is to build this learning community together. Today, we're excited to have Dr. Sean Wharton from the Wharton Medical Clinic in Canada. He's a nationally and internationally renowned expert in weight management and obesity, and he's going to be giving us the first lecture on how to mitigate cardiovascular risk with a special focus on obesity. And as well, we're really excited that the head of the nurse practitioner program at HealthPoint will be presenting our case today. So now I'm going to ask the panelists to briefly introduce themselves. So go ahead, Dr. Kelly Branch.
Hi, I'm Dr. Kelly Branch. I'm a professor of cardiology and medicine here at the University of Washington, and very happy to be here on our initiation of the new Project ECHO.
And then our other expert for today is Allison Ward. She's a PhD and a mental health expert with a focus in diabetes and diabetes distress. Has Allison been able to join us yet? Sometimes we're all busy with clinical experiences, and so I know she'll be joining us soon. So the next thing is just take it away, Sean. Go ahead.
Thanks a lot, guys. It's really exciting to be here, and you guys can all hear me well. And so what we're really wanting to do is have about 20 minutes about talking about the cardiometabolic disease and what are the targets to mitigate risk. So this talk is going to be a little bit about what I believe causes some of the cardiometabolic conditions. Then we're going to go in a little bit deeper when we go into the cases about the details of each of the cardiometabolic aspects, i.e. the cardiology, the lipidology, etc. Here we're going to talk a little bit about the inflammatory aspects. Okay, so here are my disclosures. So the objectives here are to talk about the disease burden, be able to discuss the burden of obesity, diabetes, and cardiovascular disease, and how we treat the metabolic condition, recognizing some of the targets, blood pressure, cholesterol, smoking, and the reduction in risk. And let's look at some of the tools that we use to actually mitigate this risk. And so if we look at the overall global burden here, this is a cardiovascular disease burden. And so we can see it still is one of the most predominant issues around the world in terms of causing death. So the mortality here, again, ranking in 1990 versus 2019, we can see that ischemic heart disease is still at the top, stroke at the top, hypertensive heart disease. We see some flip-flopping of some of the other cardiac conditions, but that focus on those top three conditions that we've been talking about for the past 50 years are still the same. And so let's talk about the number of global all-cause deaths from cardiovascular disease. You can see that hypertensive heart disease continues to be the number one problem. It's always up there at the top. Smoking is very high, but it continues to come down as fewer and fewer people smoke. Lipidemia is there, and of course, diabetes and the glucose challenges. The high body mass index really is absolutely there as number 5 in that list. But if we think of that, the possibility that the inflammation from the visceral adiposity may cause a number of these conditions, a high fasting plasma glucose, the LDL elevation, the hypertensive risk, then we're in a position where if we can mitigate that, can we mitigate a number of those other bars? Great. So here we have a little bit of trying to have a little bit of an understanding of what causes a number of these conditions, particularly chronic kidney disease. We're looking at the fact that obesity and diabetes and hypertension all leading to that stress on the nephron, on the kidney, progressing to chronic kidney diseases and chronic kidney disease. And obviously, when we have an improvement in diabetes, when we have improvement in hypertension, we see this risk going down. It's taken a long time to show that decreasing obesity actually has a significant impact on risk because we're always looking at the other factors it caused. But because it's such a long-term chronic condition, the question is, could you attack obesity and see an impact with kidney failure? And so more than 1 in 7 people here we know are estimated to have chronic kidney disease, but only 10% of those 10% know that they actually have chronic kidney disease. So we're talking about here, so 35.5 million people, but we know that the numbers could potentially be even higher. So in terms of screening, these are some of the American screening, right? I'm Canadian, but we do look at a number of these factors here. The blood pressure screening categories are there: diabetes, cholesterol, renal disease. And of course, in every country and region, there's going to be something a little bit different, right? For high blood pressure, it says our African Americans are screened at a higher level. So what does that do to socioeconomic factors, right? Not a biological factor. Here we have to screen the indigenous population more. So why? Because socioeconomic factors. In Australia, it's the indigenous. So in India, it's the lower caste population. That's who has the higher risk of hypertension, heart disease, and type 2 diabetes. In my country of Guyana, it is the South Asians, right? So every country has its socioeconomic group that needs to be screened at a higher level. But certainly we know that all the other levels are biological factors as we continue to move forward with this. And in obesity, measuring height and weight to calculate BMI, which has its flaws, and we will talk about the flaws: waist circumference, waist hip ratio, and waist to height ratio, which all are interesting, yet the actual screening is much easier than these calculated factors that don't really impact all that much. Okay, so if we look at obesity, we can kind of look at it as both a disease. People argue about this on a regular basis. Is obesity a disease or is it just a risk factor? Well, it just doesn't really matter. It's a problem. It's a big problem. It's a disease because it has a biological aspect to it. It has a physiological aspect, has a genetic aspect to it. So you can call it a disease because it is inherent in the person's physiology. You can call it a risk factor because it causes all of these things from the brain all the way to the toes. So it doesn't really matter what you really want to call it. You need to treat it. You need to understand it, and we need to not have bias. And so where is the main problem? Main problem is this adipose tissue. So the visceral adipose tissue causes the dysfunction, which is why we really don't want to talk about size all that much. We really want to talk about so if someone living in a large body size, if all their weight is in their thighs and in their butt, then that's not a problem. If somebody is a smaller body, but they have a big belly, that is a problem, because that visceral adipose tissue goes to the pancreas, goes to the brain, goes to the coronary arteries, and causes a problem. So we really need to try to focus away a little bit from weight and BMI and focus a little bit more on what the visceral adiposity risk is. And here, because it causes this cellular hypoxia, inflammation, the adipokines, and all the other conditions. So what we know from treatment is that we've been terrible at treating people living with obesity. Terrible. And this is an example of how bad it has been. It's usually, anyone can lose a little bit of weight, just like anyone can go to Vegas and win a couple bucks. But in general, the majority of people who return home from Vegas have lost, because that's the way it's designed. You're supposed to lose. And here, you're supposed to regain weight. You're not maybe you should regain weight. You're supposed to regain weight. So this is what every study has shown over and over again, lifestyle modification in particular. So the question was, how can we get better than a diet and exercise, when that continues to be the majority of Americans, Canadians, the world continue to look at diet and exercise as the treatment option and the preventative option also, which there's no data to show that it has any prevention status, diet and exercise by itself. So this is what we've seen over and over again. But let's go to where we now have moved to. We've moved to treatment, something that actually works. And that's because of our understanding of the neuroscience of the biology. This is the disease part. It is a disease because of the physiology, and the physiology was something that we understood in the brain. So if we look at the genetic aspects in the hypothalamus, the mesolimbic system, the frontal lobe, we've now finally started to understand that these things are all related and could be related to things even like Alzheimer's. If there's a disconnect between the frontal lobe and the hunger parts of the brain, or the ability to control those areas, so no amount of willpower will allow it to happen. No amount of talking louder or screaming at a patient will help their dementia or help them to have a memory of something. You want them to remember if their frontal lobe is not connected to their hippocampal area. So this is what happens here, is that the frontal lobe has difficulty connecting to the areas of hunger, the areas of hedonism and craving. And that's what we are now in a position to understand, how that disease can be repaired by repairing those pathways between the frontal lobe, hypothalamus, and mesolimbic system. And as soon as we lose any weight or go on any type of lower calories, so someone who's 400 pounds, they go down to 390 pounds, counter-regulatory hormones activate to try to push that weight back up. So we always try to understand, why does diet and exercise not work? Because those counter-regulatory hormones will push the weight back in a direction where it was. So the idea is do we have intervention that can stop these counter-regulatory hormones, just dampen them, squash them? And that's what we've worked here with medications that try to do that. None of these actually did it. And the side effect profile was significant. So now we're in a zone, though, by understanding this physiology, where we're clearly saying, okay, if the counter-regulatory hormone is GLP-1, or a lack of GLP-1, a squashing of it, we need to increase it. If the counter-regulatory hormone is ghrelin, we need to squash it. We need a ghrelin squasher. We need a GLP-1 enhancer, PPY enhancer, adiponectin enhancer. So that's where the medications are now moving, or the interventions are now moving. And what they need to do is need to be good enough to have significant amount of weight loss and a sustained amount of weight loss. So it's not good enough just to say that we can get 5% weight loss and it's working out okay. It's not working out okay. We need 10, 15, 20% weight loss to see the impact with cardiovascular disease. We clearly point out that the majority of people from a chronic medical condition die due to heart conditions and kidney conditions. So if you can't get to the level where you can impact that, then we're not getting to the levels that we actually need, particularly within the Western world. It needs to be sustained. You don't just need to have the weight loss and the visceral adiposity decrease for a month or for a week. You need it over the longer term. So we now have 3 generations of weight management medications that are here. And it's important to talk about these interventions from a pharmacological standpoint, because pharmacology is the only thing that is scalable. And so lifestyle modification, some of the psychological aspects and surgical interventions are not scalable. They're not scalable to a large population, when it's similar to the way that bottled water would have not been the answer to how to get clean water to Africa or to many other places. You needed a system in place to actually get water into people's homes. That's a solution. Here again, we have a scalable solution that can impact millions of people. That's why we talk about pharmacotherapy. Generation 1, we saw a little bit of weight loss, about the 8 to 10% range. Liraglutide, the naltrexone, bupropion. But unfortunately, again, we don't see significant cardiovascular benefit there. We don't see obstructive sleep apnea benefit. So we need more. We need 15, 20%. So we go to the second generation where we finally hit that. We hit 15%. So now we have a chance of seeing cardiovascular benefit. And now we're going to see even greater amounts of weight loss, where we're seeing crazy amounts of weight loss, i.e. surgical levels of weight loss. So 25, 30, 35%. So that's the tirzepatides, which is available in the States for weight management, and the retatrutide molecules phase 2. So we can talk about that. So the first introduction of this ability for us to get to a weight management range where we could impact cardiovascular disease is the semaglutide molecule. I was happy to be like the only Canadian on this group. There was some of my UK colleagues here as well. But so here we published the 2-year trial. Over a 2-year time frame, we see that curve is staying flat. So that aspect of having a significant amount of weight loss, 15%, but not 15% for a year, 15% for 2 years, 3 years, 5 years, 6 years. So here we see at the 2-year mark that we're staying at that flattened level of that 15%. So certainly there may be some ticking up as we start to move out to the 5-year, 6-year range, and that's why there may be the need for introduction of newer meds. So here we see that the newer meds. So that was what was the length of the follow-up trial? That was a 2-year trial. So the longest semaglutide obesity trial is a 2-year trial. The longest semaglutide 2.4 milligrams. Semaglutide is the Ozempic molecule, or the Wegovy molecule. So you know which one we're actually talking about. So the longest is actually the cardiovascular trial, which was a 3.5 to 4 year trial. Okay, how long should people be on it for? As long as they want, as long as they can keep the weight off. If they start regaining the weight, they start regaining their cardiovascular risk. So stay on it for as long as you actually need to. So here we start to look at the dual agonists. So the dual agonist, so think of semaglutide as a single agonist, as a single-headed dragon, a pretty fierce dragon. And then we look at the dual agonist here. This would be a double-headed dragon. So the GLP-1 is still that backbone. So that's what we really think is causing the big impact. But add on to that a GIP. Can we get past 15%? What does the GIP molecule do? We don't really know, but we know that the weight loss went from 15% up to 22%. So we're seeing a significant impact here, where if you look on the right side there, 22.5% weight loss. That's an average. That's an average. That means that there are some people who are getting 30% weight loss. That's clearly surgical amounts of weight change at the 15 milligram mark. So this is the ZEP-bound molecule. That's the tirzepatide 15 milligrams. And now we're into the triple agonist, a triple-headed dragon. So which includes that backbone GLP-1, which is the essential part. And then we have GIP and glucagon. Again, what do these two other molecules do? We don't exactly know, but we know some stuff, right? But it's not perfectly clear. Think of the GLP-1 as a really good running back that can get into the end zone. But think of it getting into the end zone a lot if it has two blockers. The GIP and glucagon block, and that GLP-1 gets in the end zone more so. So that's what you can think of as this triple agonist. So now we're seeing that we're going past 22.5. This is in phase 2 trials. So we're seeing 25% weight loss at the half a year mark, and that curve is going down, right? So the average is likely going to be around 27%, 28%. So that means there's people at 30, 35%. Who needs that much weight loss? Well, somebody does. If your BMI is 70, then you may actually need it. Or if you need the sustainability of that 15%, right? We just got a 15% and then it starts to tick down again. A cardiovascular risk starts to go back up. If you have 22%, you have a lot more space to that tick down to the 15%. And so, but all of these molecules that we're talked about are injectable molecules. So everyone on the line here, all 39 of you, can afford an injectable molecule. It's expensive, it's hard to get, it's cold chain, has to be delivered in the fridge, etc. But this is not accessible to the majority of the world. So the indigenous population, the third world, which is poor Black people in the southern United States, the people in Polynesian islands, multiple areas will not get injectable molecules, but they can get oral molecules. So an oral molecule may be an answer for access to care. So if we can see an oral molecule that is a GLP-1, so instead of having a big GLP-1 that is injected, you have the small chemical molecule that goes into the receptor. If the receptor can accept that small molecule and then the activation at the other end does all the stuff it's supposed to, then awesome. And that's what we saw here. So I was fortunate to be lead on this paper, where this is the phase 2 trial, where we are able to see at a half-year time frame, we're seeing 15% weight change, and that curve going down still. So a once-a-day molecule that can be taken any time of the day without the restriction of food or water, etc. So this is where the hope is, that these gliperons or other oral molecules can actually take the place of the injectable molecules for those who need access to care. And so let's go above and beyond. So we talked about weight loss, and we talked about some of the cardiovascular risk factors. I told you that the blood pressure goes down, the hemoglobin A1C goes down. But with all of that, what we're now seeing is that so weight goes down, but what about MASH? What about the fatty liver instance? So we're seeing that this glucagon molecule, so adding the glucagon to the GLP-1, glucagon has a lipolysis action, and that lipolysis could be within the actual liver. So we're thinking that the ones that have glucagon matched in it will likely show really good impact in terms of the fatty liver conditions. So watch for that. But again, significant weight loss is needed, needs to be sustained, and we need to have the impact in the comorbid states. We're also seeing it for obstructive sleep apnea. Again, 10% wasn't going to make it. If you have obstructive sleep apnea, you need 15% weight loss. And finally, with the medications that push it down, we're starting to see an impact here. But the biggest impact has been the cardiovascular field. So here we see that 3-point MACE decrease. And these are people who are taking a ACE inhibitor, aspirin, a cholesterol lowering agent, a beta blocker. They're maximized in terms of their cardiovascular risk decreasing. Yet, when you added a GLP-1 analog, and these people who were at risk had a previous heart attack and were living with obesity, we saw a 20% decrease, and we saw it quickly. We 20% decrease in 3-point MACE, and we saw it before even a lot of the weight ended up going down. So the question is there something about the molecule, or is it just the weight change? So, and here we're not even just seeing the hard endpoints of the mortality decreasing, but we're also seeing a lot of the symptomatology decreases. So preserved ejection fraction heart failure is clearly an obesity problem. And what we're seeing here is that the symptomatology can significantly have an impact. And so this was really good news, because some people would rather have their symptoms decreased, be able to lift up their children, to be able to walk up a flight of stairs. If you ask them about symptoms versus their mortality, they'd rather, many of them, have less symptoms than have a decreased risk of death. So what about kidney failure? Well, finally, we saw here in the FLOW trial, this is a type 2 diabetes population, but we're able to see a significant impact on chronic kidney disease. We do not have drugs for chronic kidney disease, right? There's a dearth there's not much available. The ACE inhibitors are the primary agents. So when the GLP-1 analogs finally have made their way into this field, it's been an exciting time for the nephrologist to finally have another medication besides the SGLT2 inhibitors and the ACE inhibitors that can actually have an impact in terms of renal failure. So in conclusion, so pathobiology helps to explain why the medications are effective. They help to smoothen out the pathway between the frontal lobe and the mesolimbic system and the hypothalamus, so that message of you saying that I should not eat any longer, I should maintain, I should do the best that I can be actually received, and it actually works. New medications are effective for weight loss and allow for healthy choices. The evidence of improvement beyond weight loss is rapidly increasing every single day. But still, there's still more questions than there are answers. So how much muscle is lost? Will this have an impact? How long do they stay on it? Can we do intermittent dosing? Will other things impact it? What if you don't want a medication? Why do we have to go in this direction? All those questions still need to be answered. So I believe that we need to be humble and we need to be compassionate when it comes to actual care. Thanks for your time, and I'm happy to be part of this continued conversation.
Thank you so much, Sean. That was a great summary, and we can see how passionate you are for your patients and for getting people on the right medications to mitigate cardiovascular risk and improve quality of life. One of the questions that always comes up, and it already came up in the chat, and I answered it, but I'm curious, as an obesity and weight management expert, how do you talk about the potential for weight regain if you stop the medication? And how do you, when you're starting the medication, how do you bring that into the conversation?
Yeah, I don't. I just think you're walking into a minefield. So just like, many things in medicine, if you don't know the answer very well, or you don't want to deal with it, don't ask the question. Don't get a blood work parameter that you don't want to deal with. If you know someone who can deal with it, then great. But I don't think you need to necessarily go there. So, and what exactly do I mean by that? Your initial conversation is not about how bad the person's life is going to be when they stop the medication. Your initial conversation is not to lecture them about you have to stay on the medication, or why am I treating you, or what are you doing this for? You're wasting my time, you're wasting your time. No, the idea is to be compassionate. I see that you're looking for some treatment. This is what the evidence shows. This is what the treatment options are. The evidence says that if you stop the medication, you will go back up and weight for the majority of people, but maybe that's not everybody. Maybe you can do something different. Maybe there'll be new information about intermittent dosing. Maybe by the time you want to get off it, there's a once monthly, a once yearly. So I think that those are the factors. I mean, I think the cardiologists have difficulty keeping some of their patients on some of their cardiac medications, and it's which the evidence shows that people stop beta blockers, stop ACE inhibitors. You're like, that sounds crazy? But I think we're in the same position. Everybody has the autonomy to do what they actually need to actually do.
That's a great point. One of the strategies I use is discuss that everyone's an individual, and that if your desire is to come off of the medication once you are at the weight you desire, I will sometimes say, but let's set a trigger point if you regain a certain amount of your weight, because we don't want that yo-yoing of extremes, right? To restart the medication. So I set that expectation from the beginning, and usually it's like 5 to 7 pounds for women, 10 to 12 pounds for men. And again, if they prefer to stay on the medication continuously, I'm fine with that, but we want to do what is individualized for the participant. I've also been doing a little bit more encouragement of resistance training to hopefully help mitigate a little bit of the muscle mass loss you get from from weight loss overall. And so I'd be curious, Sean, if you have any other tricks to the trade that you talk to your patients about.
No, I think both of those things are great. I think it's exactly what you should do. You can. I mean, I don't think people reach their goal weight, so I don't ever really talk about that. So it's to some degree, if you feel like you want to stop, their goal weight is always much lower than what the achievement is for what many of the medications that we've ever used. So maybe some of the newer medications, this conversation will actually change. But so I usually start with saying, if the evidence does show that weight comes back on when you stop the medication, but I don't know what's going to happen with you. And if we want to, I'm always here with you. If we want to, if you start to go back up, maybe we'll go back on. Maybe we'll go back on at a lower dose. We'll moderate. We'll monitor it the way that you said. That was great. And the resistance training is the only thing we have for minimizing the amount of muscle loss. So what happens is the factory to make muscle is still working. So the idea is protein going into the factory, and the resistance training helps to keep that muscle. There's no dysfunction in the muscle. There's no issue with them. So the thing is, if you can get them to eat protein and to do some resistance training whenever they can, without lecturing to them excessively, but giving them the advice, then it definitely works out.
Great advice. And I'm going to ask one more question. Part of the reason why I saw in your slides you highlighted both BMI and hip waist circumference was because of the new ADA guidelines that encourage us to do that. And honestly, we don't do that in our clinic because it's a little burdensome, and there is a lot of user, you have to have the appropriate technique. So I'm just curious if you could comment on that and that new recommendation.
Sure. Yeah. And I don't really think it's a new recommendation. I think they've written it out there, but I think it's always been there. It's always very clear. So it's just, so do you toss out BMI? Absolutely not. BMI is just a number. It's just a calculation. It's just, so what the problem has never been BMI. The problem is the BMI cutoffs. So when we do a risk categorization of BMI between 27 and 30, that was for who? That was for white European men. It wasn't for women. So half of the world, or more than half of the world, is cut out of the BMI cutoffs that the WHO uses. So there should be a BMI cutoff for women. There should be a BMI cutoff for African American women, for white women, for the Hispanic women, for South Asian women. So those three, white, black, and Hispanic, would be in about the same, as they're all North American. So geography is the same, et cetera, et cetera. But when we go to South Asia, then the cutoffs would obviously be different. And so I if you want to measure waist circumference, sure, measure it, but I don't think you need to. I think you can point to somebody and figure out whether their waist circumference is an issue or not. If they've got skinny legs and a big belly, they've got an issue. So I don't even agree with the waist circumference cutoffs. I agree with skinny legs and a bigger belly. So that's everyone knows that. Everyone knows what it looks like. Everyone can have an understanding of it. And I also believe that you should do their blood pressure. Why are we estimating risk by looking at BMI and waist circumference? Actually, you're right in front of them. If you're close enough to do their waist circumference, you're close enough to take their blood pressure and to do their blood work and find out what their hemoglobin A1C is. If their hemoglobin A1C is 5.4 and their blood pressure is 115 over 65, you don't have anything to do. I don't care what they look like. But if it's elevated, then you do have something to actually do. So actually do the diagnostic work that we're really good at. That's what I would recommend.
And those are all great points. I agree that visceral fat is the one that really hurts us. So, and that's pretty easy to visualize. So lots of great discussions, and now even more great discussion to come. I'm going to ask us to share Wendy's case and our slides. And Wendy, I'm going to ask you to unmute yourself and go ahead, take it away with our great case for today.
Okay, so I'm going to present a case that was a 71-year-old male patient that I saw about a month ago that seemed to maybe have some pertinence to this issue, and I'm hoping to get some great feedback. So this gentleman was doing a chronic care visit with me for hypertension and diabetes. It was my first time meeting him. And he was last seen a year ago. He doesn't love coming to the doctor. But he does monitor his blood pressures at home. They're generally in the 130s over 70s. He checks a couple times a week. He doesn't check his sugars at home. And, part of the reason for that is that he's been making some lifestyle efforts already at home. So he feels kind of like through those efforts, he has things well under control. He is taking amlodipine 10 milligrams daily and lisinopril 40 milligrams daily to control his blood pressures. And he's on metformin 1 gram twice a day for his diabetes. He's tried a couple different statins. Most recently, he was prescribed at that visit a year ago, atorvastatin 10 milligrams daily. And so he tried it on his own and just discontinued it because he was getting muscle pains. He also, several years ago, was placed on rosuvastatin 20 milligrams daily. And he stopped taking it after a couple of days because he just didn't like the way it made his body feel. And he couldn't quite remember much more than that. Next slide. So in terms of his family history, he has several brothers with diabetes, and then his older brother did have a heart attack with stenting at age 65. His parents, he said, they lived in a village without a lot of healthcare access, and they both kind of passed away and, from old age, or they're not sure why. In terms of his social history, he is retired. He used to do driving for work, both like Uber and taxi. He's married. He's not a smoker. He's never smoked, and no alcohol use. And then, part of the reason he's not really that worried about cardiovascular risk or kind of in general, doesn't like seeing the doctor, I think, is because he feels like his diabetes is well controlled. His A1C is 6.2. And then, has been on several cholesterol medicines and just hasn't tolerated them. But, he feels fine and is kind of like, if I feel fine, how bad can my cholesterol be? So you can see here, his cholesterol is significantly high. So his total cholesterol is 264. His LDL is 183. His HDL is 48. And then his liver enzymes have been okay so far. And kidneys okay so far. His BMIs currently that was one more on the last slide. His BMI is currently 32.4, but so when he was diagnosed with diabetes a couple of years ago, he did have a BMI of 34. He was up to, I think, 244 pounds. And so he did work with his wife, who cooks all of their foods, and they walked together and did a lot of lifestyle things to decrease his weight. So he's happy with that weight decrease. Next slide, please. All right. And then he has had his diabetes, screenings and standards of care. He's keeping up with them. And as I said, he likes exercising with his wife, likes walking with her. He did bring up that his wife has been complaining about his snoring. And so one of my plans from this visit is she says it's increasingly loud. It's waking her up. She hasn't noticed pauses. And he kind of hasn't really noticed an energy change, but he was interested in having a sleep study done and talking with a sleep doctor. And then in a typical visit, I will say I usually do not get this detailed with the diet. So this form, I kind of filled it out based on our conversation, which may be lacking in exact details for every meal. But he usually eats like yogurt for breakfast or eggs, and probably some bread as well. And then his wife cooks at home. They eat a lot of lentils and fresh foods and veggies. But he always has like a protein like meat or lentils. He really works on limiting his rice and like wheat flour items and salt. So that is my patient.
And now's a chance that we can ask Wendy some clarifying questions. So if anyone has any questions for her, you can send it in the chat to me, or you can just jump in. I'm going to ask the first clarifying question. Can you tell me a little bit? Looks like he's done a lot of great lifestyle changes. Tell me about his weight loss journey and if that's a goal for him.
Yeah, it was not a goal for him, but I think a couple things happened simultaneously a couple years ago. One is that he started driving a lot less, and another was that he got a diabetes diagnosis and decided to kind of focus on being healthy. So I think the weight wasn't the goal, but he didn't like getting a diabetes diagnosis or kind of some of the medical increased interactions with the medical system that were coming from that. And so he put a lot of work into doing lifestyle. So weight is not a huge motivator, I would say.
Good to know. Thank you for that information. Does anyone else have any clarifying questions?
This is Kelly. Can you take a look at the CK again? What's the CK?
Let's slide back.
Do you remember when he tried his statins, did he have elevations?
So I was like looking in the blood work for that, and I don't see that. We know that.
Okay. Yeah, they just looking at this, the statin complaints that he has are not statins. The statin complaints are reluctance to take statins rather than actual statin side effects to until proven otherwise, just because of the way that he's describing it. So I'd be worried that it's going to be kind of a mental thing that we're going to have to get through, because clearly he's got a lot of risk based on that unresolved mixed dyslipidemia. And so we can look to alternatives, which are more expensive and all of those things. But if he hasn't had a CK, which to be honest with you, I wouldn't expect anyway, but this will be an interesting nut to crack to try to get him on some kind of lipid lowering therapy, but it's clearly that he needs it.
It was like a focus of this visit for me to talk about that, and especially like talking a little bit about his brother and his brother's heart attack. And he was amenable to starting pravastatin. So I did start that at this visit. I think I started at, I don't know, I'm having trouble getting into his chart because I'm working from home and my internet's not great, but I think I started him at 20 and then we went up to 40. Would you recommend checking a CK if he's tolerating that fine, or how would you handle that?
No, it'll be a signal that's not going to help you very much, because myalgia it's very rare. It's less than 1% of the time that you're actually going to get a CK elevation, and you're only going to see, even with high dose statins, it's only about 3% of the time. The data are actually quite skewed. When you're seeing these up to 20% of the time, the data are wrong, and actually 2 of those Lancet articles should probably be revoked, to be honest with you. But when it was actually tested, we're only seeing about a 3% actual myalgia, and it does exist, absolutely does exist, but they really have to fit into that myalgia category, not some of the things that he's talking about. So I'm concerned about that, but I'm glad that he is tolerating pravastatin, and now you can potentially add on therapy like ezetimibe or PCSK9 to try to get him under better control.
And those are great points. And so that's going to be our nice transition to some of our case notes. And I believe potentially our lipid expert might have joined. So I may phone in a friend as well, and she may have some of the same discussion that Kelly already brought up. So we can always skip over that. So, when we're talking about our patients with cardiometabolic risk and diabetes and living with obesity. The first thing you want to do is just get a great sense of that patient. So this is my recap of the patient. And Wendy, this is where you correct me if I get anything wrong. So this is our 71-year-old South Asian male with a history of diabetes, hypertension, hyperlipidemia, with an absolute weight of 105 kilograms, a BMI of 31. He does appear to have a family history of cardiac disease in his brother, in the setting of high LDL and intolerance to 2 statins in the past. He doesn't have any complications from his diabetes. And what's great is he's already incorporated small changes in the form of activity and nutrition into his lifestyle. And he's here, but the final thing is he's here despite saying that he doesn't typically like going to the doctor. So I think that's a very important point. Anything I forgot, Wendy?
Sounds great.
Okay. And so what we want to do is we want to have that in a head for every patient, right? And we know sometimes the visits are short, so it may take us a couple of times to get to all that information, but those are the things we want to be thinking about with our patient, right? And so you want to know what their weight is. You want to know what their kidney function is. You want to know what their age is. You want to know what their family history is. You want to know if they're taking any medications that increase resistance. You want to know about them, the person, right? Because that's how you're going to pick the right therapies for them. You need to know their lifestyle, their jobs, how they like to eat, what they do. That's the great thing about working with these patients is you really have to get to know them to support their disease. And then, insurance unfortunately is important for what is not covered. You want to know what their other risk factors are, so other complications from diabetes. And then you want to know about their cardiovascular risk. So this was just my summary of this person. And again, all these things may not be focused at every visit, but you want to be thinking about them and then sort of weight how you should address the issues and stuff as they come up, right? And so because this is, the first time we're meeting, I also wanted to present this like how when I see for a new patient for diabetes, I ask this question. So the first question I ask everyone is, does this person produce insulin? What type of diabetes do they have? And often, and it's easy for me because I'm a diabetologist, so I'm always going to ask that question, but I want to challenge the primary care providers to always ask, even if they've had their diabetes for 20 years, what type of diabetes do you have? Just get in the habit of it because you will discover insulinopenic or more consistent with type 1 diabetes, even in a 70-year-old man. And I just diagnosed someone who was 77, who'd had his diabetes for 7 years with type 1 diabetes. So just keep that in mind. But in this case, we're not going to necessarily focus on it too much because, he's well controlled, he's older, his BMI is 31, so type 2 diabetes is the most likely diagnosis. So then the second question that we want to sort of ask ourselves every time we see our patient living with diabetes, and we're actually going to address this in the second session, so stay tuned for that, is what is his A1C goal? And we're going to talk a little bit about A1C versus time in range and the way we can look at glucose indices. But so again, we're not going to focus on it for this question, but I do think that's how you set the stage for their diabetes management, is what type of diabetes and then what is their individualized goal for their diabetes management. For him, because even though he's older, because he's not on medications that have a high risk for low blood sugars, I would say, his 6 is great. And, if we can get him less than 6.5, that would be ideal. But I'd be perfectly fine with 7 for him as well. So then the next question is, because why are we trying to control his glycemic indices? We're trying to mitigate cardiovascular risk, right? So this is the cardiovascular calculator that the American College of Cardiology has available on their website. And you can see I just put in his cardiovascular risk. Okay, chat with me. What do you think when we calculate it is going to be, what percent do you think is going to be his cardiovascular risk? And I'm going to now turn it over to Kelly, and I'm going to ask him to talk a little bit about, the cardiovascular risk calculator, and then also about its limitations potentially in certain ethnicities and races. So go ahead, Kelly.
All right, thanks. And sorry, I'm going to have to pop off in a couple of minutes, so I'll try to make this pithy. So for this particular patient, I think the patient's going to be a moderate risk. A lot of risk from this particular ASCVD, is what they call it, ASCD, or pooled cohort equation, is really going to be age related. Although he's going to be pretty significant risk because of his LDL. Now, what is not captured is that this is an individual that's South Asian. If you look at what ASCVD really comes from, I mean, a lot of this information is actually from the United States. It's from non-Hispanic whites, and that's really what predominantly this information is from. We really don't have a lot of information on South Asians, and that's being addressed. But just know that the ACVD calculator may not represent all of ethnicities, just like Sean was telling us earlier. Now, that being said, if we use the ACVD risk calculator, it gives a reasonable estimation, at least as far as low, intermediate, or mild. But in general, for diabetics, ACVD risk tends to be slightly overestimates risks in diabetics, just a little bit. Excuse me. And so there's a little bit of worse discrimination. But suffice to say that I think that, given the amount of cholesterol that he's being exposed to every day for long periods of time, and these are measured now in decades, right? Then his overall risk is going to be higher. And if you look at South Asians as a group, just in general, they tend to have more cardiovascular disease, and whether or not it's a nature or nurture thing, because South Asian food, love the food, but boy, I would not ever call South Asian food health food, but it is really delicious. But for whatever reason, there also seems to be a genetic predisposition to significant disease. Now, that being said, there are other ways to actually calculate these. We can use Framingham. Again, that was just, Massachusetts white people, to be honest with you. There's the Prevent. There's also the SCORE2, which is European, so it may have a little bit more mixed ethnicity. And then there's this universal risk, which is only US. But again, this does not capture this particular patient. But there are other ways that we can look at this. The universal risk is something that's being worked on right now because it actually gives you primary prevention and secondary prevention. But what did our patient come out to be? Was I close?
45.
Was it 45? Wow.
Yep.
Okay. Well, there you go. Very high risk then, exceedingly high risk. So he needs treatment, but we knew that without even having the CVD risk, just based on that very high cholesterol and very high LDL. We knew that he was going to be high risk plus the ethnicity. So actually, what was his age? Maybe I messed up his age.
71.
71.
Oh, sorry about that.
Why,
Sorry.
yeah.
Apologies. Okay. I had him as 51 on my brain, and my apologies for missing that. Nope. So very high risk, needs treatment. And so the diligence that you're doing as far as looking at all of the risk factors as you were doing is going to be critically important for him. And that challenge is going to be statin. Are you going to do aspirin for him? Over 20%. The guidelines say that we should be thinking about an aspirin for him, even though the data are rather mixed. So I think that there's a lot to do.
Great points there. And I'm going to ask this to Wendy, and then I'm going to turn this over to Allison Ward, our sort of like mental health expert. But do you think showing him something like this would be a motivator? Do you do calculations like this in your office, or do you think it would actually be a barrier and it would shut him down a little bit?
Yeah, I mean, it was a little hard because I didn't know him previously, but I did, because this just seemed like the gaping kind of like issue in the visit. I did actually do this in the room and show him the numbers. And I do think for him it was helpful, as well as providing like some reassurance around statins. And maybe I emphasized too much, like, oh, I think if we switch statins, this really actually is going to be a very different experience, and tried to kind of reset expectations. But yeah, I did show it to him as kind of like I really care about you, and I'm glad that you're feeling so well, but I still am like just medically really concerned about this, and I don't want a serious health issue to happen, and these are your chances.
And I think that's a great way that you were trying to do it in a compassionate way, but you were looking at his risk. And so that's where I'm going to hand it over to Allison Ward, if you can unmute yourself, because I was wondering about how you would start the discussion, but in a non-judgmental way, in a non-reactive way, especially in the setting of the brother having heart disease and, mortality from that. So, Allison, in someone who says, I don't like coming to the doctor, and that's their thing up front, how would you engage? How would you share with us how you would engage this person?
I guess I would first ask why. And I know that, maybe that he's not, given what you were sharing, where he grew up or where he lived until he came to the States, that he lived in a small village where there wasn't necessarily medical care available. So, he's been doing well on his own, so to speak. So I would ask, more, just to have him, tell his story about, like, why doesn't he like coming to see the doctor? Because, I mean, to be honest, I don't like going to the doctor. And our patients have multiple appointments to attend. If we do follow up with our appointments. So it makes sense to me why he wouldn't like it either. And I imagine in many ways he also prides himself on the fact that he has made a number of changes and in his lifestyle and his diet, and that he probably could have hoped that that would be sufficient. So I would also talk with him about what is his perspective on what it means to be well controlled with diabetes. I would talk to him more about like his health beliefs in terms of like what are the costs and benefits. And I would also be looking at this from the perspective of patient-centered care. So obviously we as healthcare providers have our own concerns about our patients for various reasons, just as Dr. Mironoff had expressed to her patient as Dr. Earhart pointed out, in a very caring and compassionate way. Yet I would also want to then learn more about, what is he wanting for himself? What are his goals? And does he actually want to make any changes? In addition to the medication that he's taking, is he willing to consider additional interventions or, like the consult with sleep medicine to help him improve his overall well-being?
The final question I had, and this is for Wendy, is did he mention to you like that one of his goals is to be on less medications? Because it's a very common theme that I hear with my patients with multiple comorbidities, and it's always a challenge to address that when we want to mitigate cardiovascular risks.
He didn't say that explicitly, but it's hard to recall. I think there probably was like a comment about all the medicines at some point.
Great. And so that's always, opening up the conversation and having the time for education and everything. And listening, I think, is a big part of it too. I love how you said listening about his cultural values and everything. And I think that will go a long way. So now we're going to talk a little bit about, non-pharmacological approach to cholesterol. And, the first thing I always tell people is we want to find what is good, right? And then we also want them to goal set for themselves. So again, you can talk at the person, but I find the best thing to do is to hear what they are doing, and then they can sort of tell you, because they probably know a few things in their nutrition or their activity that they could target, because if they verbalize it, they're a little bit more likely to then come back and have executed it. And I do tell them, the one thing I say is, I'm going to ask you, if you accomplish these things you set at our next visit, and I do write them down. So I do think that's helpful. But, if I were to pick something, in his nutrition, because he's doing better quality carbs, he is being more active, but with that very high, genetically high cholesterol, I would probably ask him to look a little bit more on fat intake, because I think he was more aware of the carb intake. And when you're talking about it from the ADA standpoint, these are their sort of points that they talk about. And, one of the big things is reduction of saturated fat and trans fats. And the reason they highlight the Mediterranean diet, nutrition, lifestyle is that it tends to incorporate, a lot of lean protein, good fats from plant-based primarily. And it's probably the most studied. And because it allows a lot of variety of intake, it tends to be, more long-term. Although I don't love the idea of calling it Mediterranean, because it does seem to limit it to a region, and it is something I think that many cultures incorporate into their eating habits. But I'd phoned a friend from our CDE nutritionist, because she was not part of this panel, and so she also said that it's real. These are some great resources for where they can look for good recipes, and always in people who may have restricted or on a set budget. These sites all then have budget-friendly things. But what I wanted to highlight from the cholesterol is just and the fat thing is just label reading, right? So what we want to do, and what the American Heart Association says, is to limit all types of saturated fat to less than 10% of the total calories. If you keep in your head a 2,000 calorie a day nutrition intake. A lot of people will go down to 1,500, 1,400, or even lower than that if we're trying to do meal replacements. But, that just to keep that in our head. But what I want to highlight is like, coconut oil, right, is a plant-based, but fat is fat. And you can see that the saturated fat is actually 12 grams in coconut oil. Ghee, which is what his choice is, which is like a clarified butter, right, is also high in saturated fat, less than the coconut oil actually, because it's clarified as 9 grams of saturated fat. And then, from that Mediterranean background, the olive oil, if you can see, the total fats are still the same, like 14 grams, 120 calories, right? But the saturated fat is only 2.3 grams. And so that, just making people aware of looking at the label for these things may be helpful. And Sean, do you have any comments on that?
On the different fat contents?
Or anything, the quick and dirty of what you tell someone in a minute in your visit that would help them maybe adjust the fat content in their nutrition.
Awesome, that's great. I don't. I'm sorry. The reason why I don't is because I don't know. I don't do the nutrition side of things. I leave it to there's a number of doctors who are really interested in it and do a great job. And there's my dietary staff who actually do it. But I don't. I tell people things that congeal at room temperature are not going to be the best. Not going to be the best things for them. And the things that don't are much better. And many of them are more advanced than I am in terms of the understanding of saturated fats versus unsaturated and the trans fats. So they listen to more podcasts and they do more reading and they have more, and I think it's great. And our dietitian does. So that's what I do. I tell them to keep with what their knowledge base is, because it's usually pretty good. Sorry, that's kind of like my quick and dirty. I know that many of these guys are awesome at
I
it.
love the point that yes, a lot of times the patients know more than we do, and right, then I'll tell them that, and I'll go back into the literature and read a little bit myself, but also the simple thing also that is highlighted, if it solidifies if it does not solidify at room temperature, then it's like a lower quality thing and tends to be more saturated fat, is a great quick and dirty. So specifically for his lipid goals, right? So we don't believe he has familiar hypercholesterolemia because he's not above 190, 200 range, even a heterozygous, but we do believe there is some genetic component to his. And that's one thing that I would highlight, is that it doesn't matter how good you are with your nutrition, your genetics are working against you a little bit. And so, maybe one thing that allows him to do a retrial or support his cholesterol. And as you can see, the goal is less than 70. And then if you've already had an event, less than 55, okay? And so what we want to show is, yes, there's different LDL lowering, because the other way to look at LDL lowering is by getting to a 50% LDL lowering goal. And usually that's the highest intensity statin are atorvastatin and rosuvastatin. And then our lower intensity statins would be like our pravastatin, fluvastatin, which can, have less likelihood to cause muscle aches. And so what I will say is that would be what my next step with the patient is. I'd probably do a low dose of pravastatin, even starting as low as every other day, half a tablet, because I just want them to start it and be confident and then go up on it. Now, I don't know if Savitha, but there's also this idea of using a higher intensity statin on an every other day dosing, or a low set dose, to sort of support the fact that they may tolerate a lower dose. And so I'm going to let Savitha then comment on that, because she educated me on what she does. And she says she hasn't used pravastatin or fluvastatin in her lipid clinic in years, except for in transplant patients. So go ahead, Savitha.
So I don't use fluvastatin or pravastatin much. Fluvastatin I have not used in years because it's not a potent statin. And especially in someone who's extremely statin hesitant, it's just not going to do the job. And then it'll give the negative connotation, oh, I took a statin and it didn't do much. So we've just gone away from using fluvastatin. Pravastatin, yes, you can use. I agree with what you said, but I do unconventional statin dosing, and I also always put the ball on the patient's side. So as Nicole mentioned, so this gentleman, he's South Asian. He probably has familial combined hyperlipidemia, especially with that family history. That is, it's inherited. There's just no gene defect. And so he's very high risk, as you all saw in the numbers. So if you can convince him to take even a very low dose of, I do sometimes half of a 5 milligram rosuvastatin every other day, or even 2 times a week, to see if they are able to handle it. I missed what his issues with the statin was, but our goal is to get him to take something. So before you move on to ezetimibe, et cetera. So yeah, so those are just some things I do.
Yeah. And so it sounds like what you did was appropriate. A low dose of every other day dosing of rosuvastatin could also be a treatment therapy based on if his perception is, oh, I already have an intolerance to any dose of the rosuvastatin versus, oh, I'm willing to try a lower dose of a more potent medication. So, and then the sixth question, and because Savitha's here, I'm gonna ask Savitha and then the cardiologist and Dr. Wharton. With an A1C of 6, would you change this patient's diabetes medications? Savitha, yes or no?
Oh, can you remind me what he's on?
Oh, just metformin.
For someone who's medication hesitant, I'd probably just leave things be.
Mm-hmm. And Sean, yes or no, would you change his diabetes medications?
I would not. I would not. I think that if he's doing well, he's not having any side effects. I would look at the potential of the dose if it's under the 2000, and he could maybe move up to 2. And I would definitely monitor. So if I see it bumping up to 6.1 or staying at 6, and we don't have a ton of evidence, in Canada that 5.6 is going to be better. So I would leave it at the metformin.
And so this is a great segue to saying that, yes, by glycemic indices, he is at goal, right? But and our old guidelines, as recent as 2022, put metformin on that top of the medication therapy. But even, for the last 5 years or so, we've been talking about mitigating cardiovascular and renal risk. And so now they've taken away metformin from the overall top and they moved it over to consider it as first choice for glycemic improvement. But the first thing we want to do and why we want to highlight this, and this is a great case because the person was very well controlled with their diabetes, is outside of glycemic control. And in those that are high risk, and his 10-year risk was 45%, we actually do want to add a medication that potentially helps mitigate cardiovascular risk, right? And so those are our GLP-1 receptor agonists and or our sodium glucose cotransporter inhibitors, right? And for sake of time, because we're going to talk in detail about all these things, is that we do want to consider those irrespective of A1C, right? And we're going to talk tons about this throughout the lectures and everything, but this is our just perfect case to discuss this. And so one thing I would do to sort of support potentially looking at his risk is the newer ADA guidelines also recommend screening for asymptomatic congestive heart failure. And so I would screen a BNP because that would be, again, objective evidence that might support things. But what I would actually do, because I want to minimize the medications, is I would actually hold the metformin, because his pill burden is, depending on the size of the pills and how many times a day he's taking it, is probably a twice a day medication of at least 2 pills. You can replace it with a sodium glucose cotransporter inhibitor because even though the efficacy isn't quite as good as the metformin, you're going to get the added cardiovascular benefit from it. And you will have to have a discussion about the risk-benefit side effects, which we again talk about in another lecture. But this way, we would not increase his pill burden, we'd actually decrease it, and we'd get the cardiovascular and probably maintain his glycemic benefits. Now, this is where, many people there, I think the jury's still out for primary prevention, except for we do have cardiovascular studies in diabetes that show that you can use GLP-1s for primary prevention. But in this high-risk person, especially if weight loss becomes his goal, and we heard that he had sleep apnea, so we may be able to mitigate some of his sleep apnea symptoms with weight loss. Those are the things I'd be talking about him with long-term if a GLP-1 receptor agonist was possible, both for dual therapy for his high cardiovascular risk, and then also potentially for some weight loss, which then would help mitigate something that he is focused on, which is something like his sleep apnea. And as we saw in our recent tirzepatide study, that benefit in those with sleep apnea. So that's the final thing that I was going to ask Sean for the last 2 minutes of our discussion is, this person doesn't have a weight loss goal. Do you think we should start a weight loss discussion with him? How would you do that?
Yeah, that is terrific. I mean, I really like that. The fact that, you're adding in the SGLT2 inhibitor. What a lot of times we do, so someone comes in with type 2 diabetes, a diagnosis of it. Seems like this person came in with controlled type 2 diabetes. So which is great, but I like the fact that we're gonna really state that even though it's controlled and they've come to us as a specialist, all based on all the other factors, the person's at risk. So an SGLT2 inhibitor would be great. I sometimes decrease it to 250 milligrams twice a day, or a 500 once a day, to give myself room for the SGLT2 inhibitor in terms of the hemoglobin A1C lowering. So I go with the SGLT2 inhibitor first. I would agree, and then you get some weight loss with that. You'll get some of the fluid off of his ankles and a number of other things. They feel great after taking it, and so I think it works out well. And then the addition of a GLP-1 analog, yes, maybe not. I think an injectable once a week, so to a large degree with the GLP-1 analogs, I almost feel like unless you have significant type 2 diabetes or coronary artery disease, and I'm recommending it as something that you need to take to decrease the risk of another heart attack, decrease the risk of your type 2 diabetes, I usually want people to come in asking me for it. Convincing somebody to take an injection once a week with all the negative press and all the issues and the concerns with it, I'm just not down for. And the insurance problems, I wouldn't invite that on myself. I would do the metformin, the SGLT2 inhibitors. Very comfortable with those two for this type of patient, and very comfortable with a GLP-1 analog when a person comes in asking me for it.
Great question, great points. And I think how we'll sort of round things out is that this is all about individualizing things for the patients, based on the patient's individual risk and then their goals as well. And so it's finding that right partnership, and that partnership and their desires may change as we increase our education about their disease processes. And that's the great thing about being a physician and getting to be part of those relationships. So I will just say this ends session 1 of the Cardiometabolic Echo. Thank you so much for everyone for being here.